Today I'll be discussing Chapter 5, which is all about antibiotics. We will cover some terms and abbreviations, talk about healthcare-associated infections, surgical site infections. We'll talk a little bit about antibiotic resistance and talk about some common categories of antibiotics that you might see used in surgery. In surgery, medications are going to be necessary, obviously, and these will be varied. So the Unit 2 of your book is going to introduce drugs and the surgical technologist kind of scope of practice and things that you guys will see. It's just important that you guys focus on specific drugs, their purposes, and is general information as well. So a good way to learn this is to make drug cards to memorize some of this information. It'll be helpful and just kind of an easy way to reinforce things we go over. Also in this book, for these chapters, we'll review basic anatomy and physiology that's going to help you better understand these drugs. So antimicrobials, by definition, these destroy or inhibit the growth of microorganisms and specifically pathogenic microorganisms. So this is going to include all the categories you see here. Antibacterials, you'll also hear these referred to as antibiotics. These are routinely used in surgery. It'll also include antiprotozoals, antifungals, antiparasitics, and drugs like sulfa and mercury. And again, the one that you're routinely going to see used in surgery are those antibiotics, also referred to as antibacterials. So it's important that you guys are aware of healthcare-associated infections. These are a major public health concern. The CDC gives good up-to-date information about rates of infections, but just keep in mind that 30% of all healthcare-associated infections in hospitalized patients in the U.S. are surgical site infections. So this means they come from surgery. By definition, an SSI is an infection that occurs at or near a surgical incision within 30 days of the procedure. So if a patient has a total knee replacement, maybe they fall down, bust open that wound, and it's been 2 weeks out of surgery, and then they get an infection, that's going to be considered an SSI. The most causative agent of SSIs is Staphylococcus aureus. So this is present in the nose if you remember back to your microbiology days, and it's also going to be found on the skin of approximately 25% of healthy people. So it's not going to necessarily be a problem until it invades a wound, and then that is an issue. So antibiotics, the thing that's great about these is these are just effective tools that kind of help us in surgery to supplement the good sterile technique that we use. It's going to enhance that. So antibiotics are natural chemicals produced by microbes to inhibit other microbes' growth. Antimicrobial agents can prevent and treat infections caused by pathogenic microorganisms. And again, we mentioned antibiotics is kind of interchangeable with antibacterial term. And these are routinely used in surgery. You can see the picture on this slide. This would be a surgical wound that's become infected. You can see how it's kind of pulling apart. It's red, it's swollen. So this is what we're talking about for surgical site infections. The Surgical Care Improvement Project has focused on reducing SSIs. So they have determined that by increasing compliance with these different things, it's going to help to reduce the rate of surgical site infections. So included in this are selection of the proper antibiotic, making sure that you're giving something that's going to kill off the bacteria that they might have. Timing antibiotic administration before incision. You want to make sure not to give it too far ahead or after incision and surgery. Afterwards, you want to discontinue that antibiotic at the appropriate time. You want to identify who's responsible for these orders, who's responsible for making sure that they discontinue antibiotic, who gives them before surgery. And then verification of antibiotic names, the times they're given, and documentation. So the surgical safety checklist was developed by the World Health Organization just to kind of ensure compliance with these things, to help keep your patients safe and hopefully not getting those SSIs. So antibiotics do occur naturally, but they can also be changed in the laboratory setting to create semi-synthetic antibiotics. When these are used to prevent SSIs, antibiotics may be prescribed for the surgical patient preoperatively, intraoperatively, and postoperatively. It really just depends what kind of surgery they're having done and whether or not they're going to benefit from it. If the surgery is something that they don't need antibiotics for, more and more times that surgeons are being careful not to prescribe them unnecessarily. Keep in mind that antibiotics only assist the immune system to fight an infection. So it's just helping us to fight that battle, whether it's natural or semi-synthetic antibiotics. They are given intraoperatively for prophylaxis of post-operative wound infection. Remember, prophylactics prevent something from happening. But keep in mind, too, that infectious microbes can come from the patient's own bacteria, and this would be referred to as endogenous, or outside the patient, and that's going to be exogenous. So bacteriostatic agents, when we're talking about antibiotics, these inhibit bacterial growth. Bactericidal agents actually kill the bacteria. So this little picture here kind of helps remind you of that. If you think back to microbiology, you'll think of the infection cycle when we're talking about how infections occur. So it has to start with a pathogen. So that would be, for example, the Staphylococcus aureus on the skin. It has to have a means of transmission. In this case, it could be the instruments that we use in surgery. A susceptible host, if you have a break in the skin, for example, when you're making an incision for surgery, that is creating a susceptible host. And then all of this in turn can create a surgical site infection. So we can use a couple different tools in surgery to identify the pathogens that might be growing. So if a patient comes in with a surgical site infection, they have to identify exactly what microbe is involved, so that way they can choose the appropriate antimicrobial agent. Not all antibiotics work on all bacteria. They are selective. So we can use either gram staining or culture and sensitivity to help identify the microbe. Gram stain is going to be a rapid identification test that's going to help the doctor to prescribe an initial course of antibiotic therapy. So it's a way of distinguishing different types of bacteria. If you remember, bacteria can occur in many different shapes. So if you look at the slide, you can see, spheres, rods, and spirals. When performing a gram stain, first the crystal violet is applied, and then the gram-negative bacteria will lose the purple stain, and bacteria are either gram-negative or gram-positive. And again, this is just going to help distinguish types of bacteria that are growing, so then they can prescribe an initial course of the antibiotic therapy. So the staining properties determine what type of bacteria it is. So when you combine the staining with morphology or the study of shapes, it can help to identify many common types of bacteria. And again, this just helps us to choose the right antibiotic to give to the patient. So you guys probably remember this from microbiology. If you did this in person in your lab, you actually performed this test. Another test we can perform is culture and sensitivity, or C&S. This is a process of growing microbes in a culture to determine the infecting pathogens and the exposure of these pathogens to various antibiotics. So you put these on inoculated plates, incubate them for 24 to 48 hours, and then to be effective, the antimicrobial agent has to have selective toxicity. This means that it will act against the pathogenic microorganisms without actually harming the host cells as well. If you see this picture here, this is a CNS swab. We use these in surgery a lot to swab wounds that are infected. Also, you might see these, if you're having a strep test, looks the same way. So the tissue is swabbed with this long Q-tip looking thing, and then it's put in this growth medium, and you'll send it off to the lab where they'll culture it and see what is effective against it. You can see here the picture of that plate that we talked about. The ones that have a big red ring around them, that means the antibiotic that they've used on that portion is pretty good at killing off that specific bacteria, so that's what they would select. Also, review, prokaryotes are one-celled microorganisms and eukaryotes are multicellular organisms. They have a nucleus. When you think about organisms as well, remember that the ribosomes are the tiny structures in them that's going to affect the binding action of antibiotics. So just a little review, not going to be any test questions about that. So antimicrobial agents are going to be classified, like I mentioned already, as bactericidal, which means they kill bacteria, or bacteriostatic, they inhibit the bacterial growth. Also, we can classify these by the spectrum of activity. So broad spectrum antibiotics are going to work on a wide range of gram-positive and gram-negative bacteria. They also have narrow spectrum. These are a smaller range of activity, so usually these are against either gram-negative or gram-positive bacteria. And then limited spectrum. Usually these are effective against just one species of microorganism. Also, it's important that you guys are aware of antibiotic resistance. So this is the ability of some strains of microbes to withstand the activity of antimicrobial agents. So it means that they just aren't going to be as susceptible to that antibiotic. Approximately 70% of bacteria that cause healthcare-associated infections are resistant to at least one of the agents used to treat these infections. So that's where it gets kind of tricky sometimes, figuring out what antibiotic to use. There's 4 major categories of antibiotic resistant mechanisms or way that they can to decrease the activity of that antibiotic. So microorganisms may manufacture little enzymes that inactivate the antibiotic. Some of them will alter the cell membrane to prevent the antibiotic from entering the cell. Others will have the target area altered so the agent is no longer effective. And then the 4th way is the microorganism may add a substance to the antibiotic, which inhibits its ability to reach its desired binding site. Keep in mind as well that superbugs are emerging that are resistant to 2 or more current antibiotics. Pathogenic microorganisms with unique resistant mechanisms are continually being identified. And then the rapid development of resistant pathogens are linked to the misuse of antimicrobial agents. So people that misuse antibiotics, don't finish the course of treatment, use them for viruses, all of those things can help to contribute to superbugs and antibiotic resistance. Also, just your normal bacteria can become resistant to antibiotics through indirect exposure as well. So you can see here the major groups of antibiotics, aminoglycosides, beta-lactams, fluoroquinolones, macrolides, and tetracyclines, and we'll talk all about these in a little more detail. The first group we're going to talk about are the beta-lactams. These are considered bacterial. There's 3 major groups: penicillins, cephalosporins, and carbapenems. Unfortunately, most agents in this class aren't effective against MRSA, also known as methicillin-resistant Staphylococcus aureus. You guys have probably heard a lot about that, but these will not work against MRSA. So in that first beta-lactam category, we said one of the groups is penicillins. This was the first true antibiotic. Natural penicillins are going to have a pretty narrow spectrum. Primarily, they're going to work against gram-positive bacteria, and you'll see penicillins G, V, and G benzathionine are going to be in here. And then also there are broad-spectrum penicillins, piperacillin and caricillin. The good thing about penicillins is they're low cost and pretty low toxicity. Cephalosporins are the next group or class we're going to talk about. There are 5 generations of these. So you kind of start with the first generation, and as you go on from there, they've evolved from a previous generation. Each newer generation has greater gram-negative properties to killing those off, and they have a longer half-life, which means they just don't need dosed as frequently. They're going to stay in the body longer. So the first generation, this is going to include Ancef and Kefsol. The second generation, Methoxin and Cefitan. And then the third generation, these may be used in treating some HAIs as well. And this would be Cefabid and Recefin. The fourth generation, Maxipine, this will have an expanded spectrum. Typically, you're going to see this used for more of like meningitis. And then the fifth generation, Telfaro, this is a new generation, and it's effective against MRSA and BRSA as well, which would be vancomycin resistant Staphylococcus aureus. Sometimes you will see some cephalosporins used mixed with topical irrigation and surgery, kind of have an antimicrobial effect as they rinse cavities out as well. Next up are the carbapenems. These are considered the last line of defense against a number of multi-drug resistant bacteria. Primaxin is going to be the first approved agent in this class. Other carbapenems are going to be meropenem, and ertapenem, and doropenem. Next are the monobactams. Astronam, this would be the only drug in this small class of drugs, and it's going to be used specifically for infections caused by gram-negative bacteria. And these are safe for use in patients who have an allergy to the other beta-lactams, like a penicillin allergy. And these can be used intramuscular or intravenous injection. Aminoglycosides. So these interfere with that protein synthesis by binding to the bacterial ribosome. Then they create little small holes in the cell membrane that causes leakage. These are going to be used for short-term treatments of serious infections. Respiratory infections, bones and joint infections, meningitis, skin infections, soft tissue, intra-abdominal infections. They do have adverse effects. They're nephrotoxic, ototoxic, so these may be reversible in some cases. Some of them may be permanent. When you look at some of the examples in your book, you'll see amikacin, gentamicin, tobramycin, and kanamycin. Neomycin specifically, you're going to see used topically only, so it'll be either drops or ointment, because it does have significant adverse effects if it's absorbed systemically. So usually this one's combined with other agents. Next are the fluoroquinolones. They're a relatively low toxicity, and they do have a broad spectrum effect against both gram-positive and gram-negative aerobes. So you might hear ciprofloxacin, naroxen, levaquin. All of those are in this category. They are synthetic drugs. Keep in mind, though, MRSA and VRE are resistant to these drugs. It can be used for systemic infections, UTIs, and osteomyelitis. Macrolides, these are partially metabolized only and excreted almost completely unchanged in the bile. Most are going to be given orally. Azithromycin, erythromycin, and clarithromycin are all going to fall in here. Tetracyclines were the first broad-spectrum antibiotics. They are bacteriostatic. Some common bacteria have developed resistance to these. They're primarily going to treat acne and rickets infections. Keep in mind MRSA, VRE, and Pseudomonas are all going to be resistant to these type of drugs. There are some new ones that have a subclass developed to kind of overcome this resistance. They can be used in some complicated infections. There are also miscellaneous antibiotics out there, sulfonamides or sulfa drugs. These have more of a limited use today. And then there's also going to be some combination antibiotic agents out there. So you may see some different ointments and suspensions. There should be a table in your book, you can look at some of the combination agents. One specifically, the colistin, neomycin, and hydrocortisone. These may be used after ear tubes, and it's just a combination antibiotic. There's some other things here that can be used as a combination, so you can look at your book for more of those as well. And then there are some individual agents. Bacitracin, we use this a lot in irrigation and surgery. It's mixed in and we'll use it to irrigate. And then all these other ones too. You hear a lot of clindamycin, mupirocin. This is kind of an ointment type thing that you can also use on nasal packing, and it's effective against MRSA. So you can see why that would be helpful. The clindamycin, to go back to that, it's used a lot in patients with a penicillin allergy, but it does have the potential for C. diff complications, higher incidence of severe colitis with this. It does reduce normal intestinal bacteria, so that's why you can have some of these issues with it. Another one is Flagyl, and this is the metronidazole, very bottom on that left category. I didn't say it very well. You'll hear it as Flagyl. It's a prodrug. A lot of times it's going to be used in IV prophylaxis for colorectal procedures. Also can be used to treat post-op surgical site infections, and then they might convert that over to an oral drug therapy. And then vancomycin, that last one there, this is used a lot in severe infections caused by MRSA. So I hope you guys learned a few things. If you have any questions, then feel free to ask me, send me a message. Thank you.